Yes, good morning, everyone, and good afternoon, depending on where on the continent you're joining us. And warm welcome to our first seminar, the UAPS panel on SRH and FP seminar. It's a pleasure to have you on. This has been a long due event. We worked on organizing this seminar within the panel for, I think, about 6 months now. In collaboration with the Gage Institute, and we are happy to launch the seminar. We want to have this every last week of the month, and we are starting today with Professor Anastasia Gage, and we're happy to have her on board. I think on the chat you can see the instructions. If you prefer having the presentation made in French, you can go to interpretation and click French. If English, you can stay on this channel. And if you have any question, please feel free to use the Q&A button to be able to ask your questions. If at some point you can hear us, please let us know also by using the Q&A button just at the bottom of your Zoom panel. Okay, so I think we can start. My name is Estelle Monique Sidze. I'm a research scientist at the African Population and Health Research Center in Nairobi, where I lead the work around maternal, newborn, and child health. And I'm also the co-chair of the UAPS SRH and FP panel. And I work with 5 panelists within the SRH panel, and I trust they're now with us, but we can introduce them later on. And I think just quickly, we'll say that the objective of this panel is really, the SRH panel FP is really to engage demographers and population health enthusiasts or researchers on the continent for open discussions around issues, various issues around SRH, around FP, around population growth and development, the implications for Africa and all that. And today we have Professor Gage, who will take us through issues around teenage pregnancies, family planning among teenage girls. What do we know so far, and also what are the implications in terms of programming for adolescent girls? So we are very happy to have her on board. So in terms of how this will run, so Anastasia, you will have about 30 minutes or 40-minute maximum, if you can do it within 30 minutes, the better, to make a presentation. And then we'll have a session of question and answer using the Q&A session button. And let's go that way. So to introduce Anastasia, Professor Gage is currently a professor at Tulane University, the School of Public Health and Tropical Medicine. And the current research focuses on adolescent health, gender-based violence, and maternal reproductive health in sub-Saharan Africa and IT. So she teaches monitoring and evaluation of HIV/AIDS programs, monitoring and evaluation of maternal and child health programs in developing countries, and adolescent health policies and programs. Professor Gage has extensive experience with the evaluation of population and health programs in the Democratic Republic of Congo, Ghana, Ethiopia, Haiti, Jamaica, Niger, Sierra Leone, Uganda, and Zambia. So a lot of countries within the continent. And prior to joining University of Tulane, Professor Gage was a technical officer, performance and result monitoring for the basic support for institutionalizing child survival 2 project. Dr. Gage has served as Tulane principal investigator for sub-agreements on USAID-funded projects, such as measure evaluation, AFIA 2 evaluation in Kenya, and the Population and Reproductive Health Associate Award. She was the 2014-2017 president of ISSP, and she also serves on the scientific advisory group of ICDDRB, the Bangladesh institution, the scientific advisory council of the Institute National of Demographic Research in France, INED, and the United Nations High-Level Advisory Board on Economic and Social Affairs. So huge breadth of experience, and we're happy to have you on board, and Professor Gage. So we will leave the floor to you, Professor Gage, for the presentation. And the floor is yours. Thank you.
Thank you very much for that introduction, very detailed actually. So today's presentation is about perceived norms, personal agency, and postpartum family planning intentions among first-time mothers aged 15 to 24 in Kinshasa, Democratic Republic of Congo. So before we start, I'd like to acknowledge my co-authors, Francine Wood, who at the time of writing was at Tulane University, and Pierre Akilimali, who's a professor at the University of Kinshasa School of Public Health. And the study received funding from the Bill and Melinda Gates Foundation, and it was funding for the Momentum Project, which was a gender transformative, integrated family planning, maternal and newborn health, and nutrition pilot project that was conducted in Kinshasa. So, as a disclaimer, the views expressed are not necessarily those of the foundation, and the funding body had no role in the study design, data collection, data analysis, interpretation, writing of the paper, and the publication process. It has been established that unintended pregnancy is a global public health problem. There are about 10 million unintended pregnancies that occur to girls aged 15 to 19 every year. And in 57 countries that have implemented the demographic and health surveys, 3 in 5 women reported they had an unmet need for, or were determined to have an unmet need for contraception right after delivery. So postpartum family planning is usually defined as the prevention of unintended pregnancy and closely spaced pregnancies during the 12 months following childbirth. And even though it has been established as a key strategy for reducing unmet need for contraception, uptake of postpartum family planning is low in low and middle income countries, about 41%. Now, adolescents and young girls or young women are particularly vulnerable because they might have knowledge gaps, they have limited life experiences, they sometimes endorse family planning myths and family planning myths and misconceptions, and there are religious and cultural norms that prohibit non-marital sex are often constraining factors. And young women may lack the agency and autonomy to exercise personal control over postpartum family planning or negotiate its use. So the context, the Democratic Republic of Congo in 2014 had a very high adolescent birth rate, about 138 births per 1,000 women aged 15 to 19. Rates of unintended births were very high among women 15 to 24, 28 to 33%. And there was also high unmet need among married women in that age group, 29 to 31%. Now, the Democratic Republic of Congo has very high institutional delivery rates, which exceed 90% in Kinshasa, for example. But despite that, the maternal mortality ratio is quite high, 846 maternal deaths per 100,000 live births, and 2 in 5 second or higher order births to women 15 to 19 occurred within an interval of 24 months. So they were occurred less than 24 months. And as we know, short birth to pregnancy intervals are risky for both mother and baby and associated with adverse pregnancy outcomes. So the primary objective was to examine the association of perceived norms and personal agency with postpartum family planning intentions. We also wanted to assess the influence of normative expectations on postpartum family planning intentions. Now, these terms will be defined in the next few slides. But normative expectations are beliefs about what others think one ought to do. For example, in many low-income settings and in Africa, sub-Saharan Africa in particular, society expects us to look after our parents when they are old. That's a normative expectation. So we wanted also to test interactions between injunctive norms which is beliefs about whether significant others approve or disapprove of postpartum family planning and motivation to comply with the wishes of those people. And we wanted to test the interactions between these injunctive norms and social sanctions for postpartum family planning use. Sorry. The analysis was guided by the integrated behavioral model. For some of you who are familiar with the theory of reasoned action and the theory of planned behavior, you can see that this model is an extension of the two theories. And in the integrated behavioral model, intention to use postpartum family planning is determined by three main factors: attitude, norms, and personal agency. Now, attitudes, there are two different types of attitudes, and we'll define them in the next slide: experiential attitude and instrumental attitude. And two different types of norms: injunctive norms and descriptive norms. And personal agency is assumed to comprise two components: perceived control and self-efficacy. Now, knowledge and skills and the salience of postpartum family planning use are not assumed to influence intention directly, but they have a direct impact on actual use of postpartum family planning, as do environmental constraints and habits. Now, the model suggests that the influence of socioeconomic factors and demographic variables on behavioral intentions is indirect, and these factors affect attitudes, norms, and personal agency. So these are the constructs of the integrated behavioral model. Experiential attitude is the belief that postpartum family planning intention or use is associated with certain positive or negative feelings. Then instrumental attitude is the belief that postpartum family planning intention or use is associated with certain attributes or outcomes. Injunctive norm is the belief about whether each referent approves or disapproves of postpartum family planning and the individual's motivation to comply with their wishes. Descriptive norm is the belief about whether most people use or intend to use postpartum family planning. Perceived control is just that. It's exactly how much control one believes one has over postpartum family planning use. And self-efficacy is the belief in one's own ability to use postpartum family planning. So the data came from the Momentum Project's baseline survey, which was conducted from September to November 2018. And the sample was purposive. It consisted of 2,418 women aged 15 to 24, and at enrollment, they were about 6 months pregnant. Their mean age was 19.8 years. They were recruited at the community level and in selected health facilities. In fact, most of them, I would say about 90%, were recruited at the community level. Data were collected in 6 health zones of Kinshasa. I'm not going to read their names, they're on the slide. And we received ethical approval from the University of Kinshasa School of Public Health and Tulane University. Written informed consent was obtained from all participants before interview. So how did we define these constructs in the Momentum Baseline Survey? So to measure instrumental attitude, we based that on rejection of common family planning myths and misconceptions. There were 8 of these myths and misconceptions, and the responses was on a 4-point Likert scale, ranging from strongly agree to strongly disagree. Injunctive norm. So now, to measure injunctive norms, we asked participants to list up to 5 people who were important to them either generally or specifically, especially when deciding about use of a method of contraception. And then we asked them whether each of those reference approved or disapproved of postpartum family planning use within 6 weeks of delivery. Now, motivation to comply. It's motivation to do what each reference thinks. And we based it on the following question. Please tell me whether you strongly agree, disagree, or strongly disagree with the following statement. When it comes to using a method of contraception within the first 6 weeks following childbirth, I want to do what, then the name of the reference, this person wants me to do. Now, social sanction for postpartum family planning use was measured by a question asking whether the community, sorry, I'm losing my voice, whether the community would say good things or bad things about a woman who used postpartum family planning within the first 6 weeks of delivery, or whether the community would be indifferent. And then normative expectations are beliefs about what others think an individual should do, and consisted of 4 items. We also measure descriptive norms, belief about whether most first-time mothers aged 15 to 24 in the community used family planning, postpartum family planning, within 6 weeks of delivery. Then perceived control, that's ranged from none at all to very little, some control or complete control, total control. And postpartum family planning related self-efficacy was the first-time mother's level of confidence in her ability to perform postpartum family planning related behaviors in the first 6 weeks after delivery. And then postpartum, and that is, for example, how much confidence the first-time mother had in performing these 7 items. For example, use postpartum family planning, even if she was afraid that her husband or partner would think she was having sex with someone else. That's one of the items. And we could talk about those items later on. And postpartum family planning autonomy. Now, broadly speaking, autonomy is freedom from external control or influence. And postpartum family planning autonomy was derived from the following question, which was asked of each reference. If this person did not want you to use a method of contraception within the first 6 weeks following childbirth, would you still do it? So these responses were summed across the 5 different responses. So to measure postpartum family planning intentions, we defined the intention as use of a method of contraception in the first 6 weeks following childbirth. That is in the early postpartum period when unmet need for contraception is greatest. And this index captured 5 likely components of the family planning decision-making process: discussion of postpartum family planning with a partner or health worker next month, obtaining a contraceptive method in the first 6 weeks following childbirth, using postpartum family planning in the first 6 weeks following childbirth, and then using postpartum family planning in that period, even if breastfeeding. And each response was on a 5-point Likert scale, ranging from very unlikely, very likely, to very unlikely. So we had to reverse code the responses to create an additive index of postpartum family planning intention. So the higher the index, the greater was the postpartum family planning intention. So these were the other covariates, the other factors we controlled for in a regression analysis. I'm not going to read all of them. Some of the first 3 are the usual ones. Then we have exposure to family planning messages, household wealth, ethnicity, health zone of residence, unintended pregnancy, previous use of family planning, and exposure to birth spacing and family planning counseling in the past 6 months. So in terms of statistical analysis, we used exploratory factor analysis to assess whether associations existed between the components of each index and how they were grouped. So an eigenvalue of 1 was used to determine the number of latent factors for the index, and a factor loading of 0.3 was used to retain items in the index. Convex alpha was used to measure the internal consistency of an index. Our descriptive statistics were basically mean, standard deviations, and percentages. And for the bivariate analysis, we examined the percentage that responded very likely to each component of the postpartum family planning intentions index. So for the multivariable analysis, it was a linear regression model. There were 2 models, and the first model was the full model. It had all the variables, and the second model added interaction terms. And there were 3 interaction terms. The first was between ethnic group and normative expectations. The second was between injunctive norms and perceived community approval. And the third was between marital status and age group. And we assessed multicollinearity using variance inflation factors, and the mean variance inflation factor was 1.6. And the analysis was conducted using Stata software version 15. So let's first talk about how reliable our indices were. So the postpartum family planning index had a convex alpha of 0.9. And most of the indices, in fact, all of them that are shown on the slide, were quite consistent. The level of internal consistency was acceptable. I wanted to point out 2 things. The mean index of normative expectations is 11.0, and the index, the maximum was 16, which meant that there were high normative expectations, generally speaking, for family planning use in the early postpartum period. And then for the postpartum family planning autonomy index, remember it has a maximum of 5. And here it is showing that for an average of 3 out of 5 named reference, the first-time mother reported that she would still use a method of contraception within the first 6 weeks following childbirth, even if those references were opposed to the idea. So first times the postpartum family planning autonomy appeared to be moderately high. So let's talk about some of the characteristics of our participants. On average, let's say about 59% of them were currently married or living together, and more than 1 in 4 was never married. In terms of 40%, 2 in 5 had completed secondary school or had higher levels of education. The unintended pregnancy rate was quite high. 82% said the current pregnancy was unintended. Almost half had never used contraception, and 39% had ever used a modern method. And about half of them had never been counseled on birth spacing and or family planning in the past 6 months when they were interviewed. And almost a third had received counseling on both family planning and birth spacing. I would also like to mention a few characteristics that are not shown on the slide. Almost 2 in 5 first-time mothers believed that community members would disapprove of family planning use in the early postpartum period. Only 12% believe that more than half of all adolescents and young first-time mothers in their community used contraception within the first 6 weeks of childbearing, following childbearing. And perceived control, I believed, over postpartum family planning use was relatively high. 46% of the respondents believed that they had complete control over use of a method of contraception within the first 6 weeks following childbirth. So let's now turn to bivariate results. And in the interest of time, I will not present all the slides. I'm going to skip over some of them. And in the next set of slides, we're going to look at differentials in the intentions index by perceived norms and personal agency. We had indices measuring many of these things, and for ease of interpretation, we divided the indices into terciles, low, medium, and high. So the first slide shows the percentage of first-time mothers who stated that they were very likely to have specific postpartum family planning intentions by the injunctive norms index. And if by the injunctive norms index. So the low injunctive norms index is represented by the blue bars, medium by the orange bars, and high injunctive norms index by the gray bars. And so what we see is that there's generally very little difference between low and medium injunctive norms index. But then when we go from medium to high level of injunctive norms, and injunctive norms is the perceived approval of specific reference to the use of postpartum family planning within the early postpartum period. We find that if there is high approval, there's an increase that's almost 2 to 4-fold between the medium bar and the high bar. And that is for all aspects, whether we're talking about discussing postpartum family planning with a husband or partner, or discussing postpartum family planning with a health worker, or the intention to get or buy a family planning method in the early postpartum period, whether it's to use postpartum family planning or to use postpartum family planning if breastfeeding. For example, the percentage who stated they were very likely to use a method of contraception, even if breastfeeding, increased from 8% among those in the low category of the injunctive norms index to 40% among those who were in the high category of the injunctive norms index. So if we look at the next slide, which is about perceived community approval. So whether the community is perceived to approve of postpartum family planning, disapprove of women who used postpartum family planning, or whether the community was indifferent. So here we can see that if the first-time mother believed that the community approved of women using postpartum family planning in the 6 weeks following childbirth, there were more who actually intended to discuss postpartum family planning with their husband or partner next month. If the community was indifferent for this particular outcome or component of the postpartum family planning intentions index, it was only 9% who said they intended to discuss. And there was very little difference also between the first-time mothers who believed the community disapproved and those who believed the community was indifferent. And that is for each component of the intentions index, whether it's intentions to discuss, intentions to obtain, or intention to use postpartum family plan. I'll now show the bivariate association between the normative expectations index and each component of the Family Planning Intentions Index. So what we see here is 4 to 11 times as many first-time mothers stated they were very likely to discuss, obtain, and use postpartum family planning if they were categorized as having high versus low intentions. And these are very strong associations at the bivariate level. In terms of descriptive norms, we have the perception, we're talking now about the perception of the first-time mother about how many, whether most, more than half of other first-time mothers in the community used family planning, postpartum family planning, or whether it was none to half. Oops, sorry. I'm sorry, I'm going the wrong way, I'm sorry. Yes, and you can find out that the family planning intentions were about twice as prevalent for each component if the first-time mother believed that more than half of the women in her community who were also first-time mothers and 15 to 24 years old, if more than half of those women used postpartum family planning, then her intentions were considerably higher than if none to half of those women were perceived to use postpartum family planning. So now this slide is showing control, the perceived control over use of postpartum family planning in the early postpartum period. And we are seeing similar results. So here, in terms of perceived control, it's whether the first-time mother believed she had no control, little control, some control, or total control. Now, total control is the yellow bar, and if we compare it to the blue bar, which is no control, we can see that 2 to 4 times as many first-time mothers had an intention to discuss, obtain, or use postpartum family planning if they had total control versus no control, if they perceive they had total versus none. And in terms of self-efficacy, which perceived self-efficacy for postpartum family planning use, we see a similar pattern. There's very little difference in the prevalence of each intention between first-time mothers in the low category and the medium category. And the percentage of first-time mothers who stated they were very likely to have each intention, it increased 4-fold between the low and the high category of perceived postpartum self-efficacy. And here we're comparing the blue bars and the gray bars. So now we'll move to the multivariable results, regression results. And here, model 1 is the base model, and we're showing both the adjusted coefficients after controlling for all covariates and the 95% confidence interval. So the first result is that injunctive norms were not a significant predictor of the postpartum family planning intentions index. Perceived community approval was more important than injunctive norms. So if the first-time mother perceived that the community disapproved of postpartum family planning use, she had a significantly lower postpartum family planning intentions index, as well as if she perceived that the community was going to be indifferent. So in terms of descriptive norms, the first-time mothers who perceived that more than half of other women, first-time mothers in the community, use postpartum family planning. Now, if they perceived that, they had a higher, significantly higher postpartum family planning intentions index. For normative expectations, which reflected beliefs about what other people think one should do. Now, normative expectations were associated with a significant increase in the postpartum family planning intentions index after controlling for other variables. And then we can see that if the community, when we go to model 2, disapproved of postpartum family planning, then the beliefs about the perceived approval of the reference, that's the injunctive norms, became significantly more important when the community disapproved of postpartum family planning. So in terms of perceived control, and this slide is a continuation of the previous model, and also shows the personal agency results. So first-time mothers who perceived they had very little, some, or total control had significantly higher intentions indices than those who perceived they had no control. We also saw a positive association between the postpartum family planning self-efficacy and autonomy index and the postpartum family planning intentions. So when we come here, the adjusted R-squared shows that the models were able to explain almost half of the variance in the postpartum family planning intentions index. And what is not shown here are the standardized betas. So the standardized betas suggested that self-efficacy and normative expectations accounted for more variance in postpartum family planning intentions than descriptive norms, 66% overall. The descriptive norms accounted for only 4% of the variance and perceived behavioral control for 8% of the variance. Finally, the results are showing, as mentioned before, that the higher was the perceived autonomy, the higher was the postpartum family planning intentions index, and perceived autonomy accounted for 5%. So what accounted for most of the variance were normative expectations and self-efficacy. So we now move on to the final section of the presentation, the discussion, limitations and program implications. So our findings actually point to the role of social influence in shaping postpartum family planning intentions of adolescents and young first-time mothers. It also shows the usefulness of disentangling the different sources of normative influence. So perceived norms and personal agency had stronger associations with postpartum family planning intentions than commonly examined social determinants of health, such as education, household wealth, residence, and age. Normative expectations and perceived approval of the larger community were more important than the approval of important reference individuals. We also found significant moderating effects when the community was perceived to be unsupportive of postpartum family planning. The association between the perceived approval of the important reference and postpartum family planning intentions may be magnified. So the study showed strong support for the integrated behavioral model, and we're in line with an extensive body of research of the association between social norms and health behaviors. The limitations were that the data were cross-sectional, correlational, could not be generalized because we had a cohort and we did not use a systematic or random sample. We had no distinction between peer norms and family norms. That is possible. We could look at that in future analysis. we only measured normative expectations of named reference. There could be unnamed reference who may have had expectations that were similar to or different from those of named reference. We really had no data on negative sanctions that first-time mothers could experience if they did not fulfill normative expectations about postpartum family planning use. Then an important consideration is that social norms may be misperceived. And so it's important to assess the actual prevalence of postpartum family planning use in communities in Kinshasa and make sure that first-time mothers who are pregnant are aware of these actual behaviors. We did not measure experiential attitude, which is a person's emotional response to the idea of using postpartum family planning. And we need to examine associations between social norms and personal agency in the extended postpartum period, which is the first 12 months after delivery. Program implications. So the study provided evidence of need for demand creation programs for postpartum family planning use by adolescent girls and young women. And addressing postpartum family planning intentions and use in Kinshasa is challenging because you have strong social norms that married women should have as many children as possible before initiating contraceptive use. And these norms coexist with negative views of the consequences of closely spaced pregnancies on children and their mothers. So we propose that multi-channel communication interventions be used to communicate the actual prevalence of family planning use in the early postpartum period, because contraceptive use is not a visible practice and norms may be misperceived. And we also think it's important to engage the entire community because there may be adult gatekeepers who uphold social norms. They may not be named, but they may exert a strong influence on postpartum family planning intentions and use than the named reference. Now, for community reflection and dialogue, it's important to create safe spaces for that in order to help shift norms. And the extent to which postpartum family planning intentions may determine use would actually depend on the extent to which first-time mothers can exercise a large degree of control over family planning decisions. So efforts must be made to empower them with the knowledge and skills to improve their self-efficacy, perceived control, and autonomy. And here are the references. The second bullet is the published paper. So for more information about questions that were asked in the survey, I would encourage you to go to the publication and click on the appendices. So thank you for your attention. And let us know if you have any questions.
So our first question is, for participants who were married or living with a partner, did you ask them whether they first got pregnant before or after marriage / living with a partner?
No, we did not. We just took their current marital status at 6 months gestation.
Wonderful. Thank you. Next question is, were there any differences in results based on age, 15 to 19 versus 20 to 24 years, for example?
We are looking at that, but more in terms of, because Momentum actually implemented a community-based project, and we have a paper that's under review that looked at the impact of the project on 15 to 19 never married and ever married or living together women, and 20 to 24, and we're finding differences, especially in terms of whether the project had an impact on perceived norms. We didn't have any impact on perceived norms, injunctive norms, normative expectations for 15 to 19 never married. We did not. And we do have a paper that's been published where we lumped the 15 to 24 group. We analyzed them as one because we had too many results to show, and the description of the results was getting confusing. But where we break down by age and marital status, we are seeing differences, especially in terms of the impact of the project on postpartum family planning outcomes, including perceived norms, discussion, obtaining a measure of a family planning method, and actually use of a family planning method in the extended postpartum period. So that's a very good question. That we need to look at these separately and by marital status.
Wonderful. Thank you. And what resources would you recommend people looking to learn more about postpartum family planning with new mothers, whether that be research or hubs online? There are any tools that you recommend?
Yes, there are lots of articles now that have been published on postpartum family planning, and thank God for open access. We now have access to many of such publications through pubmed.gov, but then the World Health Organization also has very good resources about the kinds of messages that should be given for postpartum family planning by health workers. And we drew heavily on that guide when deciding on what messages should be given out by. We use nursing students to implement the intervention at the community level for our pilot project. And we do a lot on the guidance provided by the World Health Organization on postpartum family planning related messages. And you can get a lot of information from work that has already been done. There's not much that has been done on the 15 to 24-year age group, but the resources are increasing over time.
Next question is, do service providers have a negative influence on family planning use? And has the study been compared with other studies?
Okay, so service providers. Now, for our intervention, we worked very closely with the Ministry of Health in the Democratic Republic of Congo. They wanted to have a higher level, a higher caliber of community-based health providers. So we worked with them and drawing on experiences from a former project, Aqua, that had been implemented also by Tulane University under the leadership of Jane Bertrand in DRC, in which we instituted a community-based internship for nursing students who were in their third and fourth year students. They used to do their internship in health facilities, but because of the need, the community need, and the need for scientifically trained health workers, the Ministry of Health was interested in having an integrated internship also for these nursing students. So on the Momentum Project, the nursing students provided they did home visits and group education sessions. And the home visits were to identify women who were having their first baby and were 6 months pregnant. And we integrated family planning and maternal and newborn health interventions. So at the time of the baseline study in 2018, we were basically giving out messages on postpartum family planning and also messages pertaining to maternal health, especially care during pregnancy and the importance of postpartum care. So it was in that context that we did the study. The study, what we are finding out is that using nursing students, it's a cost-effective way of providing care at the community level, a higher level care, because the nursing students provided messages, they actually provided care and referrals, and they were linked with health facilities. And the government of the DRC has scaled up the family planning component, and now we're scaling up the maternal and child health component. So they developed a scale-up strategy, and we're piloting that scale-up strategy now in 11 nursing schools in order to integrate gender as well as the maternal and childhood components. It's a lot of stuff that's going on. And we're doing a process evaluation of that scale up to see what quality could we get of care could we get from the nursing students when the project has more or less, it's kind of living and scaling things up, and what are the implementation problems and constraints and potential solutions as we are scaling up.
Thank you, Professor Gage. I'm back online. I think my internet was fluctuating a bit. Yeah, but this was very great, interesting presentation. Yeah, and I can see you answering questions already and doing some fantastic job in terms of engaging policymakers and nurses in DRC. And I think we all know that DRC is a very challenging country.
Yes.
And I have a lot of needs, especially regarding family planning, maternal and child health. So for me, I think this is a very interesting study. I don't know, Molly, and Molly, thank you for chipping in. I don't know if there are any other questions.
Sure, there's one more. This last one says, this is an interesting study. Do you find that this is the same pattern in other African countries?
Oh, we have looked at some of the findings for postpartum family planning intentions in other countries, basically not just African low and middle income countries. We're finding some similar patterns for those who use community health workers, but we were using, this was before the intervention started. So we find similar patterns, but the measurement of social norms and their relationship and examination of their association with postpartum family planning intentions has not been well studied in sub-Saharan Africa. At least there may be studies out there that are not yet published. So I should say that the published literature is thin on that topic.
Yeah, thank you, Professor Gage. Yeah, and I think we're just building on what you just said. I remember some times ago we were discussing with some university in the US around funding studies on agency and also on autonomy among women in terms of using contraception. And one argument that we're making is that actually to increase the demand for contraception, I think perhaps we should look more into how much users we can have if we increase women autonomy and agency. So we should not take it for granted that actually women have autonomy and agency that they need to use family planning. So I think those kind of fundings are very interesting.
Yes, I agree, and I think we also need to address social norms. Yes, to address social norms. And I think that right now we need to know what are the effective interventions that can help us shift those norms in favor of family planning. And not just in favor of family planning, but there are also other health outcomes. But what interventions, how can we implement interventions, and what components should they have, and how can we actually shift those norms that are constraining? Because sometimes perceived norms are correct, sometimes they are misperceived. And if disapproval, for example, community disapproval is correct, how can we shift that?
Yeah, thank you. And then I think that my last question, the question I had for you, in terms of implications of your study generally for unintended pregnancy and population growth. We always talk about the population of Africa growing very fast, still very fast, especially in West Africa, and Central Africa, where Democratic Republic of Congo is located, so very high fertility rate. So for you, what do you think the implications of your study in terms of really understanding population growth and reductions of population growth in Central or Western Africa? So maybe a few words around that.
That's a very difficult question to answer because there are so many determinants. There are so many determinants.
Okay, but generally, what do you think? Yeah.
Well, I think it comes back to high fertility norms. How could you change that? So if we look at, excuse me, if you look at the total fertility rate and calculate that by women's education. You could find that among women who completed secondary school, you're looking at total fertility rate sometimes between 2 and 3. And if you look at least according to some of the DHS surveys that were done in the between 2000 and 2016. And if you look at the total fertility rate among women who have never been to school, sometimes you get levels of 5 or 4. There are parts of West Africa which have the same total fertility rate at some cities in Western Europe. If you take parts of Accra, or some cities even in West Africa. So I think, although we think that, okay, if we have to give women family planning methods, we also have to address the underlying determinants. And I think norms, social influence, social pressure tend to be fairly high. There was a time when I was asked why I did not have 4 children. I was in DRC at the Ministry of Health. So I had fewer than 4. So one has to think about what are these norms that are driving people's behaviors.
Yeah, exactly. Thank you for that. I think, yeah. So thank you for the presentation. I think we don't have much time remaining, about 2 minutes to go. So
Okay.
I think mine is just to again thank you for this very interesting presentation. And if there's any questions, comment, they can still the participant can follow up with you, and we can
Yes,
let you know.
yes. They can please feel free to email me. I'll be happy to share our instruments for data collection.
Yeah, and then also maybe perhaps I don't know, Professor Kenny, if you're online, to also perhaps introduce Professor Kenny, who is the chair of the FP and SRH panel.
Okay.
Yeah, we have worked, as I said, the past 6 months intensively along with the Gage Institute to be able to set up these seminars. And we are hoping to have, as I say, we're hoping to have one seminar every 3rd week of the month. So starting with Professor Gage, thank you for starting us off. Professor Gage, it was a pleasure.
Anytime.
Yeah, it was a pleasure. And next month we'll have Dr. Jason Bremer from Family Planning 2030, who will talk to us about family planning measurement advancement. So we hope to have also all of you joining and continue those nice discussions around family planning in Africa. So I think maybe for next time. So so thank you again, Professor Gage. Thank you everyone.
You're welcome. It's a pleasure.
Have a nice evening, everyone, or a nice day, depending on where you are. Thank you. Bye.
Thank you. Thanks for having me. Bye-bye.
Bye.